Hey y'all, for those of you that are in and getting ready to start the presentation, if you could please sign in with your full name, your section number, and your instructor, it would greatly help. Also, I need to see your bright shining faces, not just a picture. So that way I can gauge your responses to things and make sure that you're comprehending or understanding and being able to participate. So you can go to your reactions button, and if you need something, you can just kind of, wave the clap sign. It'll stay up there for a little bit. Okay. And then, or you can unmute yourself and ask a question. So it's good to see everybody, and nice to be able to view you instead of you just listening to us drone on a PowerPoint that's, that we're just talking about, and you have no way to ask questions on the fly. And so my name is Miss Leaf. I am a charity grad from December of 1992. I was in the first class that got an associate's degree from Delgado. And I have been teaching since 2002. So my background initially, nursery, postpartum, pediatrics. So I felt that flexibility was breeding job security. So that if I was called off in one place, they could use me in another. And I do med-surg. I've always done med-surg here and there. So that's not foreign to me at all. As you join us, please sign in and put your full name, sign in chat, put your full name, your section number, and your instructor, please. Okay, it's just about time to get started. So today is inflammation part 1. I will be recording this session, and I will put up a recording this afternoon after I've done all of the classes on part 1. So, it won't be up there till about 1400. After this class, after the class in the afternoon, I will open the discussion board so that if you have any questions, you can post them there. Discussion board is so that, if you have a question, you can post it there, and then I can answer it, and everybody can see the question and the answer because they may have the same question. Okay. I'm also gonna give you my phone number. Which is in the chat now. It's 504-453-2037. So that if for some reason you need to speak to me privately or whatever, you can text me your name, what team you're on, and what you need to ask me, or, if it takes a call, that's fine too. Okay, but that's how you reach me, 504-453-2037. I wouldn't, emailing me, is okay, but I don't necessarily check everything every day, especially when I'm in clinical, and I'm in clinical 4 days a week, Wednesday through Saturday. So this way, by texting me, put it out there now. We'll check discussion board every 24 hours. So that's kept up too. Okay, everybody hearing me okay? Yeah? No? Who cares? Okay. All right, so yeah, just keep signing in with your full name, your section, and your instructor. That's how we're going to take attendance. Okay. So people keep joining. That's a good thing, I think. So I have Dr. Uini's 2 groups, Miss Kyle's, Miss Campbell's, Miss Payne's, and Miss Hanhart. Okay, for this morning. So let's get started. All right. All right, can everybody see the PowerPoint? Yes, no, maybe so, certainly. Huh?
Yes.
Okay, cool. I'll put the chat over to the side. So if you have any questions and you don't want to speak up, you can also post them in the chat box, and I will be glancing over there to see if there's any questions, and then I can answer them on the fly as well. Okay, so this is inflammation part 1. All right, so these were the couple of slides to be done before class. Okay, can anybody give me the definition of inflammation?
It's an adaptive response to injury or illness that brings fluid or plasma, dissolved substances and blood cells into the interstitial tissues where the invasion or damage has occurred. It's an innate immune response.
Okay, so is this a normal body response?
Yes.
Yes, absolutely. Okay, so you should have crossed the this before, the inflammatory response before, when you dealt with wound healing. Okay, there's always an inflammatory response, and then you know, they go into the stages of wound healing. But yes, it's to whatever the body sees that is harmful. Physical agents, mechanical objects that cause trauma to the tissues, excessive heat or cold. And this includes surgical incisions, okay, that we make. Physical agents, chemical agents such as poisons, strong acids or alkalis, or even internal irritants such as hydrochloric acid. Microorganisms, bacteria and viruses elicit inflammatory responses, and allergens as well. So, very good. Now, so what are the 6 signs and symptoms of inflammation? And you can either type it or say it, doesn't matter to me.
The 6 signs are pain, heat, exudate, swelling, impaired function of body parts, and redness.
Very good. Okay, so pain. You like my neat little function here? I don't have a
That's
whiteboard
nice.
yet, and so I'm trying to write with my mouse.
Improvising at its best. I say improvising at its best.
There you go. So, ooh, edema. Okay, heat. And so, impairment or loss of function. function is going to be FX, abbreviation. Good. And exudate. Now, all right, so when we're with a patient, how do we know, or how can we gauge how much pain a patient's in?
Ask them to give you a pain scale from 1 to 10 to judge their pain.
Okay, good. All right, so there is what's called the symptom analysis, and the mnemonic device is PQRST. Okay, to help you drill down what's going on with the patient. P is position, and provocative for palliative. So where is the pain? Okay, what makes it worse? What makes it better? Okay, is there a body position which helps relieve some of that pain? Q is quality. Okay, what kind of pain is it? Is it dull? Is it aching? Is it stabbing? Is it throbbing? Is it burning? Is it itching? Itching can be a discomfort, you know. So was it an abrupt onset, like, you know, really fast, or has it, you know, been building over time? Region, or actually radiation. So does it radiate anywhere? You know, with gallbladder disease, a lot of times it's in that right upper quadrant of the abdomen. It'll radiate to the back. So will pancreatitis. You know, sometimes things radiate up into the shoulder. So those are important things to know. S is the severity scale. So on a scale from 0 to 10, 0 being no pain, you know, and if they're having pain, they should rate it from a 1 to a 10 being the, you know, the very most pain they can tolerate. And so have them rate it, and then make sure you know what their pain scale or their pain goal is. And that is the number of which on the pain scale they can tolerate to be able to still do their activities of daily living and be able to function. Okay? And then timing. You know, is there a certain time of day when this occurs? Is it in the morning? Is it at night? Is it after meals or before meals? You know, is it when you're bending over? Is it what's going on, you know, when this pain occurs? So that should help you, you know, with narrowing down. Okay. And then impaired function. Did anybody have induration for that? Okay. So induration happens that I can think of twice. Okay. Because induration is what? What is it?
Hardening.
Okay. So it's a hardening. It's a hardness, right? So if these are normal functions for the inflammatory response, do you think that an organ is going to harden?
No.
Okay, good.
Yeah.
Okay, so, you know, you'll have impairment of function or loss of function of that organ, but it won't get hardened. Now, induration does occur when you have things like your PPD, TB test, you know, skin test. And what they're looking for is not the redness that occurs, it's the hardness and the millimeters of hardness that occurs at that spot of the injection. And that will tell them if you're positive or negative. Okay, so in induration. The second type is with a mosquito bite. You know, you kind of scratch it or whatever, or it stings and you get a hardened whelp right there. And then eventually it goes away. So those are the two that I can think of for induration. Now, you will have induration with infection, pockets of infection that are walled off, say, by an incision, or even, anybody watch Dr. Pimple Popper? Okay, so those kinds of cysts and things that are filled up, and those are hard. Okay, so yes, all right, but it's most of the time it's not, you know, that inflammatory response. So okay, so as you can see, I need to get my eraser and erase this, otherwise it'll show up on all my PowerPoints. Isn't this cool, huh? I can't wait to get my whiteboard and see what I can do with this. All right, so stages of inflammation, what happens? Okay, now the first stage is the vascular and cellular response. Okay, so we talked about some of those things when we were talking about the symptoms, the signs and symptoms. So you get the pain is from the tissue damage and the pressure of the accumulation of fluid, okay, the edema that hence goes there. The redness and the warmth are due to the increased blood flow to the area to bring the much needed white blood cells and nutrients and things like that to be able to keep this from getting any bigger or any more into the system. And then of course also the warmth is from the dilation of those blood vessels. So the edema comes from when those dilation of blood vessels occur, so there's an increased capillary or vascular permeability that leads fluid, proteins, leukocytes, the histamines, kinins, prostaglandins, all those kinds of things to go to the area, okay, to deal with this, this injury or this agent that the body sees as harmful. And so the blood flow slows in those dilated vessels, okay? And then the functional impairment of the body part is due to the edema and the pain. And exudate is from the fluid that escaped from the blood vessels. So we're going to talk about, well, right there. So types of, okay, let me finish with, okay. So the stages, so there's that first vascular or cellular response, okay? And then stage 2 is that exudate production. So a lot of times, say you have a paper cut on your finger, and after the bleeding stops, okay, you might see a light, clear yellow crust that forms on that injury site. And so that is to help it heal. That's all that protein rich and fluid and stuff to help it heal. Okay, and then stage 3 is the reparative phase, which repairs injured tissues and regenerates and stuff. And then of course with the granulation and all of that. If you're just joining us, please sign in with your name, your section, and your instructor, please. Okay, so we're going to types of exudate. Woohoo! All right. So, tell me a type of exudate.
Serous.
Okay, serous.
Serous, sorry. It's
That's okay.
clear.
Okay.
Sanguinous.
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 Okay, good.
That's bloody. Purulent.
Good.
That's yellowish brown. And serosanguineous, clear with blood.
Serosanguinous. Good.
Okay,
Good.
serosanguinous.
Okay, very good. All those fibrinous and all that kind of stuff, can describe some of these things, but the main types of exudate are going to be the serous, okay, which is your clear, light yellow exudate, okay, and that's a good thing. That is just the good juices coming to help with healing and stuff, and that lets you know that it's on its way to healing, okay. Initially, what you might see, especially with surgical cases that are returning from surgery and have maybe drains in them, okay, or dressings, you might see sanguinous, which is bloody drainage, okay. So you might see that. Then serous sanguinous is a combination of these two. So what do you think that's going to look like?
White with strips, like streaks of blood.
Okay, you're close.
Okay.
Close. What is serous?
Like light
Is it
pink.
white?
Maybe pink. Like light pink.
Okay. Pink, you're only gonna really get if the red blood cells hemolyze some and the color of the red blood cells diffuses into the plasma, which is your serous exudate. Okay. How many of you have ever had blood drawn?
Me.
Okay. Have you ever looked at the tube afterwards? What does that tube look like? What's at the top? Isn't it that clear, light yellow?
Yellow, yeah.
What?
Yellow.
Okay, so clear, light yellow or yellow fluid, okay? That's your serous part. And then below that is your sanguinous part. That's all the blood cells and all of those that have settled to the bottom, okay? So same thing when you're looking at a drain or something on a dressing, you'll see the blood kind of maybe in the middle, and the serous part will be out a little bit more, and you'll see a just kind of another stain around that, and that would be serous. So that would be serosanguinous. If it's in something that's being that's holding it, like a JP drain, hemovac, a wound vac, and you'll see it separate out like we talked about, okay? And so, and then purulent, okay. What about purulent?
Plus.
What do you think we'll see?
Is it like yellow, brown?
Okay, you can see all colors of the rainbow practically, okay? So big thing is it's going to be opaque, okay, or something you cannot see through. You know, think of serous as your clear liquids, things you can see through. Your sanguinous is tomato juice, okay? And your purulent is everything else. It can, you know, that you can't see through. And it could look milky white, it could be green, it could be yellow, it could be brown, it could be tan, it could be all kinds of colors, okay? And it may have an odor and may not have an odor. And those are the things, instead of just putting purulent drainage, you need to add those adjectives. And the reason you need to is because those are going to be directly responsible for when you tell what you see to the doctor, he's already clicking through his mind what kind of bacteria it is that is causing those things. So, yes, and so it bears further explanation, and all these do is there is there a scant amount? Scant means barely any. Is there a little, okay? If you can measure it in the JP drain or the Hemovac or whatever, then you can get a milliliters, okay? Or if on the dressing, is there a little, is there a lot, you know, so, or what we would call large amount, okay? So, Purulent. I see some people are putting down this word. Pus. Okay, let me tell you about pus, tell you a story, okay? When I first started teaching, I taught level 1 and I taught skin integrity and I taught infection. And I was teaching skin integrity and about what you would chart for, you know, complete charting on a wound or something, you know, surgical incision. And so one of my colleagues said, oh, teach, you can use mine. You can use mine as an example because mine's perfect, you know? And I was like, oh yeah, I said, well, let me read it. So I'm reading it and it says, patient with low transverse abdominal incision, approximately 6 inches, well approximated. Y'all know what that means? Meaning that it's closed. And then if it has like, if it's closed with staples, or you can mention that, but is it well approximated except 1 inch on the left is gaping, okay, with redness and heat noted and pussy drainage, period. Now, what I told her and what y'all don't know is that I worked in forensics before I was in nursing, and this was way before CSI and DNA, okay? So I was an expert witness for trials on all the evidence that I tested, and my field was blood and body fluids. So I always chart with a lawyer on my shoulder because I know what they're going to do. So I told her, I said, what happens if this goes to court? You know, you get a notice in a year and a day that they're filing suit. It might not be anything you did, but they're filing suit and they're going to need your testimony. But the trial may not happen till five years later. Okay, so you're just kind of scrambling your brain thinking, who was this, what, you know, and you're reading over your notes. And so she gets to the trial, okay, and they ask her to sit down and they do everything, and then they say, can you please look behind you? And what they're going to have, but this is going to be in huge, like 250 font, bold and bright red behind her, okay? And turn around and say, could you please tell me what that word is behind you? And she's gonna turn around and say, pussy, okay? And then they're gonna ask her to start reading her documentation. And she's going to get down to the end and then suddenly realize, okay. So, but she's got to say it. So pussy drainage. And then they're going to ask her to spell it. And she's going to say P-U-S-S-Y. And they're going to say, wait a minute. Isn't that what's on the board back there behind you? What did you say that was? You know, and if you're hesitant, they're going to say, please answer the question, you know, as everybody heard you say, pussy. So that's what I thought you said. Now, everybody's going to be hysterical in the courtroom, but what have they just done? What has that lawyer just done?
They are not credible.
Okay. Basically, null and voided any testimony that she may have for that case and discredited her. Okay? So always use descriptive characteristics, purulent and medical terminology. Purulent, you can't go anywhere with that. That is a medical term. And then description thereof, green, you know, all that kind of stuff. Now, fibrinous, you can have fibrinous clots in sanguinous drainage, and so they're kind of stringy looking clots. So you can put how many you found, or you know, what you're seeing, okay? And then that way there's nothing, no place to go for them, all right? So, because you just never know what's gonna go to court for what. And it may not be anything you did, it might have happened in ICU before they got to you or wherever. All right, so can there be infection without inflammation?
Yes.
No,
No.
no,
I put no.
yeah.
I put no,
Yeah,
that there
and-
can be inflammation without infection.
There can be an infection in autoimmune disorders and immunosuppressed patients.
There you go.
Oh,
Okay. Autoimmune disorders such as what?
Like lupus.
Lupus, good. RA, right? Rheumatoid arthritis.
Arthritis.
HIV,
Cancer.
okay. Autoimmune, also, we're going to touch on that because Crohn's and ulcerative colitis are also autoimmune. Okay. Now, autoimmune is a little bit different from immunosuppressed. So immunosuppressed are patients who, what?
they don't have an immune response to infection?
Or very little, yeah.
Okay.
So actually immunosuppressed is going to be people like
Is that people on chemo or no?
chemo, yes, absolutely. Okay, it suppresses the production of their white blood cells. Okay, and so it's gonna, you know, they're not gonna be able to mount an inflammatory response. That's why those patients on chemo are told that if they get a temperature of like 100.4, okay, or even 100.2, that they need to go see their doctor or go to the hospital immediately, because it could be an infection. They might not be able to mount, you know, our defenses like we have for a fever of 101. That's part of our defenses. That's why a lot of pediatricians don't like you to give a lot of antipyretics, acetaminophen, ibuprofen to children, because their fever is a way for, that's part of their systemic inflammatory response. Okay, so also immunosuppressed can be those that are malnourished, okay, that don't have enough protein in their system, and protein is needed to make white blood cells and those kinds of things. Okay, so very important. Oh, good. Somebody mentioned the elderly. You know, the elderly, their immune system is sluggish, you know, at best. So it takes longer for it to come about. So when the elderly have an infection, what's mainly the first thing they see, or that like their family would see, or you would see as a nurse?
Redness?
Confusion.
Confusion?
Oh,
Confusion.
confusion.
Confusion. Okay. So very much confusion. My mother had surgery. She had right here on her chest, she had from a portacath and stuff, she had a hernia. okay, which meant this chest wall was not covering what it was supposed to be covering. And what's underneath there? Your lung,
Your
right?
heart, your lung.
Okay, so she would cough and this thing would bulge out like a bullfrog. Okay, so yeah, and so she coughed a lot. She had a respiratory illness. And so she went surgery and had a mesh put on there. Well, she went home and she said she thought she was running fever at night. She didn't feel like taking her temperature, but she was waking up just sweating. And I told her, I was like, well, Mom, did you tell your home health nurse? Well, my home health nurse told me that it was just hormones. Now, this is a 78-year-old lady. They don't have hormones. They're lucky if they have ovaries. You know, the ovaries are probably the size of an eraser head. So I told her, I said that you're running fever. And she says, oh no, you know, I'm fine. And then she started talking, you know, off her head. So I had to make the call for them to come to go get her. She was in another state. But yeah, so confusion is gonna be a big one for the elderly. And so, you know, their temperature runs where?
Usually.
Low,
Low,
like around 95, right? Or 97?
99.
Even lower, yeah, so it's going to be a little bit above 95, hopefully 96 or so, 96.2, you know, 96.4. What did they teach you in level 1 was the range for them? It was like 97 to 99 or something, but some fall a little bit below that. And so they're, you know, Helen gone from, they reach 101, and you're talking, that's like us being at 103 or something, you know, for them. So we definitely have to watch them. Okay. So the signs and symptoms, how they relate to the, well, let's go over the exemplars. So here are the exemplars. GERD, gastroesophageal reflux disease. What organ does that have to do with, or organs?
Stomach, esophagus.
Stomach.
I can't see.
Okay, the stomach, and what else?
Esophagus.
Esophagus, very good, thank you. Absolutely. And peptic ulcer disease?
That's stomach as well.
GI tract.
Stomach, yes, stomach. Okay, cholecystitis,
Inflammation of the gallbladder.
gallbladder. Good, you guys. Hepatitis,
Liver,
liver. Pancreatitis.
pancreas,
Yeah, that was kind of a no-brainer. Inflammatory bowel disease,
That's a GI
Crohn's, and ulcerative colitis. Now they happen, they can happen in the same area, but most of the time,
right, Lord.
Crohn's is going to happen where? Does anybody know?
Right lower quadrant?
Okay, actually right mid-quadrant, and that's going to be in the small intestines. Okay, because Crohn's is known for blocking your small bowel, having a small bowel obstruction occur. Okay, but it can be anywhere from, you know, the stomach all the way down to the anus. You can have Crohn's. Okay, what about ulcerative colitis? Does anybody know?
In the colon.
Colon.
Yeah, the large intestine and the anus and the rectum, absolutely. Okay, and we're going to talk about some of those tests that we will do now, because those are the organs that we're going to talk about. Now, remember how you had to have A and P 1 and 2, and you had to have AMP2 within 5 years, okay, this is where it's going to raise its ugly head, because you need to know those organs and what their functions are, right? Because when they're impaired, when those functions are impaired, we as nurses need to know how to intervene, and our interventions are based on that impairment. Okay, so if you don't know what the functions are to begin with, then you know, it's going to be tough. So please review your A&P. Okay, so we went over what organs are involved. Where are they located? So esophagus is where? Y'all could show me. Right, runs here, okay? And where does it terminate?
At the,
In the what?
this-
Yeah, in the stomach. Good. Okay. So PUD is in the stomach, and the stomach is kind of in the middle and a little bit to the right of the mid-abdominal quadrant. Okay. Mid-abdominal and a little bit to the right. So what's going to be in the upper right quadrant of the abdomen?
Gallbladder.
Good. And what else?
Pancreas?
Nope. The liver.
Liver.
Good,
Liver. Oh, okay.
good. Liver. Okay. So you know that. Now on the left-hand side, okay, is the pancreas, left upper quadrant, but it kind of goes behind the stomach and things. So you can have a mid to left upper quadrant, and then they also feel it in the back, just like with liver and gallbladder, they can have radiation to the back. Okay. And then going down, we talked about the other two that are in the intestines, usually Crohn's right mid quadrant, and then ulcerative colitis left lower, okay, in the intestines. All right, almost at break time. So general assessment for inflammation, you know, you want to take a good patient's history. That includes medication history, so that you can see what they've been dealing with and what's going on with them. And then conduct a focused assessment on the affected body system, and then your physical assessment. So what would be your focused assessment?
The area that's having the problem.
Yeah, so in this case, generally, what area is affected by all of these organs?
The abdomen.
Abdomen.
The abdomen, okay? And so how do we assess the abdomen?
We're gonna do the
Palpation.
IAP. Oh,
Palpate. Oh, go ahead. I'm sorry.
What do you do first for the abdomen?
you're gonna inspect.
Inspect. Very good. So you're going to inspect for what?
Any
Inspect.
distension?
Yeah.
Good. Size, right? Is it flat? Is it concave? Does it have a dip in it? Is it round? Is it obese? Okay. So, you know, you need to have those things, because you need to paint a picture with this. All right. And or is it distended? Okay. That's going to be different from just round and you know, and the distension, you'll find out if it's hard, you know, or soft, but you know, you're looking at this point. So what do we do next?
Auscultate.
Auscultate, very good. So when we auscultate, if we hear bowel sounds every 8 seconds, how are we going to classify those bowel sounds?
Hyperactive. Hyperactive.
Hyperactive.
Hyper.
5 to 30 is hyperactive, right? 5 to
5 to 20 is normoactive.
normal active. Okay.
So if you hear it every 8 seconds, that's going to be normoactive vowel sounds. Okay, that's the only thing that you really need to remember, because hyper, just like a hyper kid doesn't stop, okay, that's going to be your vowel sounds. There's going to be very little, relief in between those sounds. So it's going to be less than 5 seconds in between sounds. Okay, and hypoactive is going to be greater than 20 seconds between sounds. Okay, and you got to listen to all the quadrants, because some may be hyperactive, some may be normoactive, or hypoactive. It all depends. And then you also, when you're listening, when would you say that that vowel sounds are absent in a quadrant?
If you listen for 5 minutes.
Good. Okay. So, and that's just in one quadrant. So how could you say that there are no vowel sounds at all in the abdomen?
When you listen to all of them for at least 5 minutes each.
Yeah, so that's 20 minutes. Okay, you got to spend auscultating the abdomen. Very good, very good. Okay, so after auscultation comes what?
Palpation.
Palpation.
Okay, well, before palpation, now we don't do that, but if you see a doctor or a nurse practitioner do something before they palpate, it's going to be what?
Percussion.
Percuss. Okay, so they're going to percuss, and they're going to be listening for density of organs and sounds in the abdomen. Okay, and then palpation. So we do some light palpation, right? So that's where we're going to determine if the distension is soft, if you can press into it, or if it's hard. Okay, if it's tympanic, like if you just tap your finger and you can kind of, hear the noise, or if you can lightly move the abdomen and it undulates, okay, that means there's plenty of fluid in there. Okay, so it's fluid. And usually those are people that have some kind of cancer, or they have a liver that's cirrhotic, chronic pancreatitis, something that remember the edema we talk about and the fluid leakage? Well, that's what's going on. There's an inflammatory response going on, and that fluid's going in the abdomen. Okay. Well, I'll tell you what, it's a little bit early. Remember to sign in with your full name, your section, and your instructor. And it is about 9:15. So come back at 5 till 9, and you guys take a break, grab some coffee, do whatever. I hope this isn't too boring, but we'll continue on. Thanks.
Thank you.
See you in a bit. Okay, we're back. So can everybody still see the screen, the PowerPoint? All right, good. Thumbs up. So one thing I wanted to tell you is for exam purposes, okay, when you have a 2-hour course, like, or a 2-hour session like you did for elimination yesterday, they're going to have 8 or 9 questions on your exam so that you can bank on. So for every 2 hours, you're going to have 8 or 9 questions. Okay. For something like inflammation, that's 4 hours, 2 hours this week, 2 hours next week. We're going to, you're going to have between 16 and 17 questions on an exam. So for this first exam, I will have 16 or 17 questions on inflammation on this exam. Okay. Everybody get that? So now, you know, when you get to perfusion, and that's a 6-hour, okay, you're going to have more like 25 questions on perfusion. But that's the only 6-hour course we have. Now we do have ICR and sexuality, which are both in 2 hours. So it's an hour of ICR, an hour of sexuality. So basically they're going to be 4 questions on intracranial regulation and 4 hours on sexuality. I mean, 4 questions on sexuality. So for each, you know, each hour. So that's kind of how it's broken down. Okay. Next thing. Oh, and as you're going to see, we're in assessment. All of our SLOs on for each concept, all of the SLOs are somewhat the same, that they're based on the nursing process. Okay, so you go by the nursing process when you're studying your notes. That's kind of how I'm presenting this, as well as next week we're going to be doing a compare and contrast of the interventions for the disease processes, and I'll get more into that. All right, so gathering diagnostic and laboratory data. Okay, diagnostic data such as, you know, tests that are being performed. There is a test, okay, called an EGD. EGD, which is an esophageal duodenoscopy, which I wrote in your chat so that you could see. Okay, so that is a procedure in which anytime you see something with scopy or scopy, okay, it has to do with sending down a camera to visualize, okay, to visualize. A lot of times they'll do an EGD, and it's pretty much the gold standard now to visualize what's going on with the esophagus, see if there are any lesions, any erosion or anything going on there. And then down into the stomach, okay, where they look for ulcers, they look for, you know, redness and excoriation in the mucosa. They can get biopsies of the ulcers and cultures from there, and that's where, because on the outside we can see the redness, we can see the edema, you know, we can feel the heat, that kind of thing, but on the inside you can't see those things. With the scope you can. Okay, you can see if it's edematous, you can see the redness, you can see if there's any exudate or ulcerative activity going on. Okay, so that is a very big plus. Okay, So the other, one of the other tests that is used is an ERCP, which is an endoscopic retrograde cholangio pancreatography. Big long names, hard to spell, but just know that you won't have to spell them. You just have to recognize them and what they do. So an ERCP, again, is a visualization. It views the common bile duct, which is the duct that hooks the pancreas and the liver and the gallbladder together, okay? And they view the pancreatic ducts, so they can tell if they're edematous, if they're reddened, okay? If they're blocked by a gallstone that's causing pancreatitis, hepatitis, you know, those kinds of things. And hepatitis, you're gonna hear me refer to that, but hepatitis in this case means inflammation of the liver, not the viruses per se, although we will be going over those. With the ERCP, it can be combined with a surgical procedure, sphincterotomy, to remove gallstones from that common bile duct and insert stents or catheters or whatever need be. Okay? So another procedure would be the sigmoidoscopy and proctoscopy. Okay, sigmoid meaning visualizing just the sigmoid colon, proctoscopy, the anus and the rectum. Usually with anything that's going up that end, they're gonna visualize the rectum and the anus at some point, okay? And this way, the sigmoid is the lower part of the large colon. It can detect polyps, tumors, sites of bleeding, an extent of the inflammatory process, ulcers, those kinds of things. And they can do it for ulcerative colitis. They can look at it for Crohn's, you know, whatever they think is there. Diverticulitis, right? So, or diverticulosis. Colonoscopy is visualizing the whole large intestines, everything, the ascending, the transverse, all that, okay? They screen for colorectal cancer that way, and it's useful for diagnosing inflammatory bowel diseases, removing polyps. They can perform biopsies, etc. Okay, so whenever these procedures are done, you know, for colonoscopy, whenever the intestines are inflamed and there's an acute inflammatory or acute exacerbation of what's going on, is it the time to do a colonoscopy? Answer?
No,
No.
because wouldn't
Why?
that like irritate it or hurt it more?
Okay, with possibility of what?
Di- Yeah.
Peritonitis.
Perforation.
Perforation that can lead to peritonitis. Okay, all that gunk spilling into the abdomen.
Miss
So-
Leafy,
Yes,
I'm sorry, what time are we supposed to return? I'm just trying to see how much I missed.
oh, 8:55.
Okay,
You didn't miss that much.
okay,
I've gone over an EGD. You're good, and plus I'm gonna post the recording. You're okay.
okay, all right, thanks.
Okay. So, you know, EGD, however, that can be performed because they use that when somebody's got a bleeding ulcer and they're bleeding. They put the scope down, see where the bleeding's occurred, and they clamp off those ulcers to stop the bleeding. Okay, very, very rarely do they perform gastric surgery. They used to in the old days, they don't anymore. Okay, so Yeah, there are just too many complications that can happen in an acute exacerbation. Now for Crohn's, you know, because of it kind of lives in that small intestines. It can be anywhere, but we can't visualize it, can we? It's too much intestines unless they're going to swallow something and they're going to watch it go all the way down. But that is not feasible if they suspect a small bowel obstruction. Okay, so what they might do is give them a little bit of contrast and stuff and send them for a scan to be able to see if that contrast makes it through or not. And if not, then there's a small bowel obstruction that's probably going to need surgical intervention. Okay? Okay, and there are going to be other procedures that we're going to talk about, but those are the big ones. And the thing with those procedures is they shouldn't have a fever going in, and they most certainly shouldn't have a fever when they're done. Okay, so you know, those are the important things. So if they have a high temperature or an increased temperature after the procedure, then something happened. You know, in an EGD, did they aspirate? Did something get perforated? You know, same thing with the colon. So all that kind of stuff has to be monitored. Okay. All right. So those are mainly procedures. When we're talking about, oh, in this next slide, you guys don't even worry about it. I didn't change it to this slide on yours, but again, it's just manifestations of inflammation. Local, you see what it is. Systemic, basically the temperature is going to go up. To me, those temperatures didn't make sense. You know, an oral, just for inflammation, we're not talking infection. So an infection, it's going to be greater than 100.8 degrees, okay? Pulse greater than 90, respirations greater than 20, white blood cells kind of greater than 10, but not very much more than that, still within normal limits, but on that high side. And you're going to be keeping track of your patient. And as those white blood cells increase, you know that there's something going on, okay? So don't worry about this. I'm not going to ask you this kind of a question, you know. Just know when it goes systemic, you're going to see this temperature going up, and you're going to see white blood cells going up, okay, toward infection. With the inflammatory process, it is short-lived, okay? It is a short amount of time. When you have a surgical incision, when they first come back and maybe a day after, you're going to see slight redness around the incision, maybe some edema, maybe some heat, but it should get better over time, okay? Less redness, less heat, less edema, okay? And you see the healing going on. If it goes from the initial redness and it gets more red and more edematous, and the incision starts gaping a little bit, and, you know, so those kinds of things, then you know you're headed for infection. And the laboratory data can back up that hypothesis. Okay? Does that make sense to y'all? Yeah? Yeah?
Yes.
Okay. Okay. So, strictly talking about inflammation, there are these two top laboratory tests, okay, that denote inflammation in the body. First is the SED rate, or erythrocyte sedimentation rate. And that measures how far the erythrocyte, which is a red blood cell, settles in a tube over 1 hour. They usually have a scale for males and females. I'm keeping it simple. It's one scale, 0 to 20 millimeters per hour is normal. Anything more than 20 millimeters an hour denotes presence of an active inflammatory process, okay, where the red blood cells stick together and settle faster, causing a higher reading. When I test you, I am not going to give you a 21 or a 22, okay? It's going to be in your face, okay? So just know that. C-reactive protein, okay, or a CRP, normal is less than 1 milligram per deciliter, okay? And it's produced by the liver and the fat cells in response to the inflammatory process. So anything that's 1 and greater, there's an inflammatory process going on, okay? And with these two tests, the higher the number, the more inflammation there is. What doesn't it tell you?
The reason?
Where the inflammation is located. Good. Yes. Where is the inflammation? Okay, I've got some questions. ESR for systemic inflammation only. Yeah, local inflammation is usually localized until it goes systemic. When people get fevers and things like that, then it'll go. But sometimes you'll just, you know, it may be nominal, maybe a small amount that shows up. But usually when we see them in the hospital, there's a large amount of inflammation going on. Or you can suggest, if you have somebody that's a surgical patient or a wound and you can see that the inflammation is getting worse, you know, pain's getting worse, everything's getting worse, you might want to suggest to the healthcare provider to, you know, draw a SED rate or a CRP on those people. So both are non-specific and tells us how hot the fire is, just not where, okay? So the CBC with differential. The differential has to do with those neutrophils, basophils, all those different kinds of things. I'm not gonna hold you to those, okay? I want the basic CBC. White blood cell count, red blood cells, hemoglobin, hematocrit, and platelets, okay? And your lab sheets, okay, from clinical, you'll find it under the clinical tab. Those are the ranges that I want you to know, because on tests, those are the ranges we're gonna be testing you on, okay, those lab sheets. So your CBC is here. It is on page 2, okay, and it does have the differential there too, but just so you know, okay, so the 2 different pages, those are the ones we're going to go in for ABGs, for all those kinds of things you're going to learn. Those are the ranges, okay. So, and you've got to have them memorized. There are going to be other things in this, in inflammation that you're going to have to memorize it, put it on flashcards, start getting to know it. You're going to have to know it for clinical, and you're going to have to know it for other concepts coming along the way, okay? So, and we're going to be mentioning more next week. Anybody have any
Professor.
questions?
Yes, we're supposed to know white blood cells, erythrocyte. What else did you say?
Hemoglobin, hematocrit, and platelet count.
Hemoglobin.
Here, I'll put it in chat. So,
Thank you.
Okay. Hemoglobin. Hang on. For some reason, my hands aren't cooperating. Okay. So you got to know the ranges for all of those things. So now we come to problems, okay? So we have inflammation going on. So we need to know, we need to prioritize actual problems as opposed to risk come first, okay? So, and it's always A, B, C, airway, breathing, circulation, or so it would be respiratory and cardiovascular is how you would do your problems. Anything respiratory is your first priority. Anything with circulation, cardiovascular is your second priority. Okay, same thing with testing, and we're going to go over that tomorrow or Thursday, depending on when you have me for test taking and study skills. So, and then comes whatever your patient specific needs are. You know, do they have falls? Have they had falls that have caused them problems, and maybe from an inflammatory situation? So we want to make sure that they're free of falls. You know, so there are different things going on. Maybe it's wound, all those kinds of things. So, you know, the risk for problems. Now, the only time I make an exception for risk for that takes priority is the risk for aspiration. Okay, because that is a serious problem, and that needs to be up there with airway. Okay. Goal setting. Okay, extremely important. Now you see, I'm kind of going in the way of care plans. And the reason why I'm doing that is because this is part of the way we think, and we're going to be going into something else called a clinical judgment model. And we're going to be introducing that in clinical. So you need to be able to come up with, you know, number one, you have a hypothesis, which is basically asking yourself what is going on here. So, you know, what is the problem? You know, where's this coming from? And have your data to back it up, or cues. But goals or expected outcomes, you can put that up here, must be specific to the patient, realistic, measurable, and achievable within a given time period. Say short term, maybe a week or two, long term meaning prior to discharge. Okay, and then a maximum of three expected outcomes, not a whole slew of them. Sometimes one might be appropriate. Okay, you have a risk for falls. Your expected outcome is the patient will not fall. There you go. So your evaluation of that expected outcome. So for your first day, did your patient fall? No, then patient did not fall. For your second day in clinical, you know, day 2, patient did not fall if they didn't fall. So those goals were met. Okay, if they weren't met, then we need to go back to the expected outcomes and see, you know, were they realistic? Were they achievable? Those things in the care plan book are not measurable, achievable, and specific to the patient. Okay, so you need to make sure to gauge that to the patient. Okay, So now we get to the nitty gritty. Again, I said, because of the functional impairment, that our interventions are going to be tuned to that. So for injury, okay, we want to reduce the mobility of the involved area. And you'll see this, you know, mainly it's for like your extremities, okay? But it can also be for the abdomen or whatever. If they've had chest surgery, if they've had abdominal surgery, they're gonna move some, okay? They need to turn and those kinds of things, but it causes them pain to be able to do too much, and can be detrimental because it might put undue pressure onto the surgical incision. So it all depends on what the doctor wants them to do. Elevate to reduce edema. Kind of hard to elevate an abdomen, but arms, legs, all that's fine. Antipyretics is needed, and then anti-inflammatory medications. So we're going to be talking about anti-inflammatory medications, okay? And some of those are indeed antipyretics as well. So other kinds of interventions and therapies include surgery, okay? Like for cholecystitis and ulcerative colitis. Cholecystitis surgery, we're gonna what? What does cholecystitis have to do with?
Gallbladder.
Okay, if it's inflamed / infected, gangrenous, whatever, we're gonna what? We're gonna want,
Is it an ESR? Are we gonna send like a visual? No.
nope. Actually, one of the diagnostic tests that's really, really good, non-invasive, they're gonna send, because of signs and symptoms, they're gonna send the patient to ultrasound.
Ultrasound? Yeah.
Yep, which is gonna be, that's gonna be the gold star for that. Okay, they'll see gallstones or a bunch of sludge or whatever. And then right after that, they're gonna send for what kind of consult? A surgery consult.
Surgical?
Yes. To do what?
To have it removed.
There you go. Y'all were making it harder than it seemed, huh? Get that puppy out of there, okay? So yes, to remove that. Ulcerative colitis.
You say for the
Different from,
colitis. I'm
I'm
sorry,
sorry?
Ms. Lee. You say cholecystitis. They're gonna do the ultrasound.
first for diagnostic purposes,
Okay.
okay? To make sure that's what it is. And then they'll schedule the surgery consult,
Okay. Thanks.
okay? And for ulcerative colitis, now it's different from Crohn's. Crohn's has skip lesions, which means they're not contiguous, they're not joined, okay? So, but ulcerative colitis is, it's usually one whole area. So what they'll go in and do is snip the end on one side, and then the portion that's infected or affected in the middle, snip the other side, and then reanastomose the ends or tie them off together so that that's one continuous non-infected piece, and they remove that. The other thing they may do is form a man-made fistula. What is a fistula?
Some type of opening from one passage, one area to another.
Good. It's an abnormal opening from one organ to another, okay? So in this case, it's going to be in the intestines, okay? The colon to the skin, okay? And so basically that man-made fistula is called an ostomy, okay? And that's where the stool is going to come out. So depending on what's going on and the severity of the nature of the illness, that is what they're gonna do, one of those two things. Antibiotics, we're gonna administer antibiotics for inflammation caused by infection. Steroids for those instances of severe systemic inflammation that may not warrant surgery or other things. And we're going to talk more about those. Dietary support, including calories, protein, carbs, vitamins for healing. A lot of times, you know, when you see somebody that has acute and severe inflammation, that they're in a hypermetabolic state, okay, to try and heal and things. So if they don't have the proper calories, the proper amount of protein to make, you know, to repair these cells and repair the damaged tissue, then, you know, they're going to be ripe for an infection, and then an infection's even going to cause more problems. So we might want to get the healthcare provider to get the dietitian and nutritionist on board. When you're talking about the elderly and even some other people, they may not eat a lot of that meal. So it's very important to get the percentage of meals that they're eating a day. So they might do well, instead of those 3 large meals, doing more of a 6 small meals, which it would include supplements such as Ensure or Vital or Nepro, Glucerna, those kinds of things, to give them the added protein, nutrients, and calories they need. Some more interventions. We want to prevent further injury. Okay, so we don't want anything else to happen. So if something occurred from a fall, we don't want them to fall in the hospital. If they have some kind of bleeding tendency because their liver is not functioning properly, we want to prevent them as well from falling, because they could bleed quite a bit. We want to assist with the activity as ordered, bed rest, up with assist to the bathroom, whatever. And, or even if they have to get up out of bed or walk a couple times a day, you know, we want to make sure that that happens to continue with their recovery. Also assist with hygiene and ADLs. So brushing their hair, brushing their teeth, washing their face. You know, sometimes they'll order occupational therapy, which is OT. Occupational therapy deals with basically from the waist up and the strength of the upper body and the coordination, so that they can, you know, do those things for themselves. So we can push for as much independence as possible. And then PT is physical therapy, and it deals from the waist and below. And it deals with the strength of the legs and the lower body, and being able to ambulate even with an assistive device, but being able to do that with, you know, some steadiness and stability. We want to make sure to alleviate any discomfort, you know, from nausea and vomiting to itching to pain, any of those things. And use your alternative pharmacological measures such as music therapy, distraction, you know, visual, you know, imagery kind of thing. And be able to get them to kind of, you know, relax in those senses, which usually helps with the pain. We like to just throw pills at them, but, you know, there are different ways to kind of calm the pain down until the medication can work, okay? So, you know, for IV opioids and different things like that, for IV push, even Zofran, which is, or ondansetron, which is a antiemetic, you know, you give it IV push within 15, 30 minutes, they should feel the effect, and you need to document that of what's going on. By the way, you don't chart asleep. How do you know they're sleeping? How would you know if they were sleeping?
You ask them how they're sleeping? Like you talk to the patient and ask?
Well, then they wouldn't be sleeping.
Eyes closed.
Oh,
Yeah.
I'm sorry, I thought
They
you
meant
meant to be at rest. I'm sorry.
The respiration and the,
Eyes closed. Rise and fall of chest noted.
There you go. Okay, so you can't chart asleep. You chart what you see. Okay. When I was in the hospital, I used to keep my eyes closed because I didn't want to be bothered. You know, when you're feeling that bad, it's like, you know, do whatever, keep my eyes closed. So, you know, eyes closed, restful expression, unlabored breathing, you know, with, and noted, you know, and then your safety things. Chart what you see, okay? And then to promote coping and decrease stress, you know, one of the things we're here for too is to help them find resources. Nowadays, especially with COVID, you know, people are having trouble finding ways to pay their hospital bills, their doctor bills. You know, if they do have a job, they're afraid of losing it because they're hospitalized, those kinds of things. So we need to help them decrease stress. You know, they're worried about their kids, all kinds of stuff. So to reach out to, you know, places, get somebody involved to help them with Medicaid and food stamps or whatever to get them through this. Okay, so some more interventions. Here we go with the pharmacological, which are aimed at reducing the inflammatory response and pain. Okay, so what are the nursing considerations with these types of drugs? Okay, so NSAIDs, non-steroidal anti-inflammatory drugs. So what kind of drugs are those?
pain relievers and anti-inflammatory.
Yeah, that's NSAIDs, okay. And so what, name the drugs.
Oh, ibuprofen,
Good.
naproxen,
Naproxen sodium, good.
acetaminophen.
Nope,
No, that's
That's
Tylenol.
Tylenol.
I'm sorry.
that's an antipyretic and pain reliever, but it's not an NSAID. Okay. Anybody else? Oh, there are,
Aspirin,
okay, aspirin,
Aleve,
Aleve is naproxen. Okay. Aspirin's not really an NSAID per se, but it's definitely hard on the stomach. So, you know, we need to be mindful of that, just like NSAIDs are. Things like Voltaren, Toradol, Relafin. There are hundreds of anti-inflammatory meds out there, especially that orthopedics use, okay? Which, because now they found, because it's so hard on the stomach as far as an irritant to the gastric mucosa, and they can cause ulcers. And ulcers look a specific way when it's caused by an NSAID. And so now they're coding these these NSAIDs with either an H2 receptor blocker or a PPI so that it does not irritate the stomach as much. Okay, so NSAIDs can lead, to possibly ulcers. Also can lead, so if they're having pain after they take that, that's stomach pain, that's not good. We got to look for black tarry stools, which indicates some bleeding from the stomach, because you'll know it's black and tarry, that it's from there because it's been digested. When it's frank red blood in the stool, it's coming from lower in the colon. And then also NSAIDs are also an antiplatelet aggregator, so they'll bleed more. Okay. Meloxicam. Yeah, meloxicam's another one. Glucocorticosteroids. Steroids. What do we have to watch as far as steroids go?
Infection.
Blood
Okay,
cells.
they will mask that inflammatory response. Okay, but it is an anti-inflammatory, potent anti-inflammatory. So it will bring down the inflammation. But yeah, it makes infection a little bit harder to detect as well. So, you know, we need to watch for that. That's why a lot of times doctors will cover like their asthma patients. You know, they put them on steroids, but they'll put them on antibiotics too, because usually there's an upper respiratory infection or something that's occurring that's triggering the asthma, and or they want to cover them in case an opportunistic bacterial infection does come along. What else about steroids?
The glucose. The glucose.
Hyperglycemia. Oh.
Okay, the hyperglycemia, yeah, y'all are all correct, with the increase in blood sugar. Okay, now to Joe Blow, who has no, you know, pancreatic problems and does not have diabetes, the rise in blood sugar is probably going to be nominal. You'll just see it when they draw like a basic metabolic profile or a complete metabolic profile, and we'll talk about those. If we don't get it this time, we'll talk about it next time, but glucose is in there as well as electrolytes. So glucose,
Right.
you might see it go up to 110, 120, which shouldn't be a big deal, and it will come down once, you know, steroids are discontinued. So, but those that have diabetes, okay, they may, their sugars will rise, okay, and you might hear them say things, oh, my sugar's never been that high, okay, and you can tell them, you know, you're on steroids, this increases your glucose level, infection and inflammation, just by very definition, increases your glucose level. So even though your diabetes keeps you, you know, within the range that you like it at home, we're gonna still keep you on that, but you're gonna need some sliding scale insulin for when you go over and these parameters are given. So we may be giving some sliding scale insulin to keep them more under control. Okay, so what else can happen with
Weight gain.
steroids? Weight gain, good. Absolutely. So they're going to have to watch their salt intake as well, because they will retain fluid. When somebody gains weight of like 3 pounds in a 24-hour period, what kind of weight is that? Is that fat or is that water?
That's water.
Absolutely. You don't gain weight like that from, you know, excessive calorie intake in a day. It doesn't happen. It's water weight. Okay. And how do we tell about somebody's hydration or fluid status an accurate way?
You
You
wear
take
them every
their-
morning.
There you go. It's not INO, because INO is only as good as the people that record it. Okay. It's not skin turgor. It's going to be weights, daily weights. And they're going to be done in the morning, before breakfast, after voiding, with the same clothes and same scale. I'll repeat that. Okay. So daily weight should be done in the morning, before breakfast, after voiding, same scale, same clothes. Okay, and so they gain 3 pounds. We need to watch that, because where is that weight? Is it, you know, is it in their extremities, their lower extremities? Let's auscultate their lungs. Is it in their lungs? You know, we need to find out where. You know, a weight gain of 5 pounds is extremely significant, and we need to let the doctors know. Okay. So very good. That was very good, you guys. Opioid analgesics, again, nursing considerations. What is the side effect that normally happens with them?
Constipation.
Okay, constipation. So if they're on these drugs on a regular basis, then we might want to ask for stool softeners to be prescribed for that patient. What else? What else is another side effect?
Respiratory distress.
Well, yeah, hopefully we don't get there by the amount that we're giving them, but it could happen. So yeah, especially if you're giving it IV push, you know, the minute you see those respirations go down below 10, you know, or 11, you need to stop, you know, stop the infusion, and then possibly get some Narcan, because they can't handle the dose that's being given to them. So the side effect that I'm talking about is the drowsiness or the sleepiness, okay? Because if they feel like they have to go to the bathroom and they're drowsy and they're sleepy, what can happen? Falls, okay? They can, you know, so we want to prevent injury and stuff, and tell them that they have to call for assistance when getting up to go to the bathroom, okay? And then we watch for all those, and we get their pain scale. And then again, if they are quote unquote asleep, you know, within that 30 minutes, if we're given IV push, if we're given PO within that hour, we have to chart against it and put what we see if the eyes are closed, etc. Natural therapies are things like turmeric and cinnamon and those kinds of things that you might see on their home medication list, okay? And so we want to look at that and make sure, especially discharging them home, to make sure that none of those natural therapies interfere with the drugs that or medications that they're being sent home on. Does that make sense to you guys?
Yes.
You know, all that ginkgo biloba and those kinds of things, they all have, you know, effects on medications, and you just need to know if they're going to affect them adversely or even synergistically where it makes it more potent, because that can be detrimental as well. All right. Where am I? Okay, so now we're on basically evaluation. And this is where we see if they meet the expected outcomes we've set for them. We give you an illustration of a care plan. So we're talking about they come in and they're recovering from urosepsis. So this person ended up in the ICU with a UTI that went, and they went septic, okay? And so now they're back on the floor, they're still getting their antibiotics, and we're still watching for the signs and stuff. So we're gonna set out, you know, what expected outcomes that they're gonna have for infection. You know, they have the infection, they're not at a risk for. So an expected outcome is going to be reversal of the cues that you get that show that are abnormal. So maybe in the last CBC they had in ICU, the white blood count was 22,000 per millimeter cubed. Okay, and so one of your expected outcomes that by discharge they will have a white blood cell count of 5 to 10,000 per millimeter cubed. Okay, and then also you want a temperature. Now, if this is an elderly person, you know, you want them to have a temperature between what, 97 and 99, or 96, you know, 4 to 98, 4, whatever. Okay, so you want, that's what you want their temperature to be. Okay, and then what else about, you know, if you're talking about a wound or something about that, but if you're talking about a UTI, you want to talk about that their urine is clear and yellow, you know, with a 24-hour total of whatever 24 hours times 30 is. I think it's 72. So, you know, you want 700, at least 720 milliliters in a 24-hour period of clear yellow urine, right? Because if they have a UTI, it's going to be cloudy, it's going to be dark, and those kinds of things with some blood in it. So you want it clear and yellow. So when you evaluate those goals, you're going to do interventions, and we're going to talk about those. You're going to do your interventions, one of which is going to be your monitor your labs, your monitor CBC. You know, you're going to do I&O maybe every 4 hours, accurate I&O for this patient. And so, and also you're going to be doing their vital signs every 4 hours in PRN or whenever. So those are the interventions that are going to cover you for that. You go to your expected outcomes, and maybe they did a CBC today and their white blood count is 15,000. Okay, so it's not met yet, but those goals are, that ranges for discharge, but it is coming down. It's not staying or going back up. Okay, so what we're doing, like administering the antibiotics and things like that, are working. For that temperature, what was the temperature at 8 o'clock in the morning? What was the temperature at noon? And then you've got to do it the next day too, okay, for those. And then also, what does the urine look like? Is it clear and yellow, or is it something different? And you do that for both days. Depends if you're there for 12 hours or if you're there for 2 6-hour days. Okay, does that make sense to you guys? Okay, so for next week, what I want you to do is, let's see. Okay. Okay, so you see this sheet right here? I want you to make something similar to this for next week. Some common interventions that you would do for all of the exemplars, okay? And then what's going to be specific?
You have your
the
screen.
PowerPoint came back
Yes,
on.
ma'am.
Huh? Okay, hang on. Oh, it's not letting me.
Dog eating ice cream.
Yes, it does. So that's my Mag. So she's no longer with us. I have 2 others. But okay, so can you see me in my picture? I know it's hard to see.
Yes.
No, I don't see you.
Is that better?
You have to click on her picture.
Yeah, if y'all
And it's
click on her
gonna blow her.
picture, if y'all click on her picture, it'll blow it up.
Click on my picture. All right. So common interventions, GERD, hepatitis, PUD, cholecystitis, pancreatitis, and then IBD with Crohn's and ulcerative colitis. So what I want you to do for next week is look up some of those in the book, okay? And get yourself a definition so that you know what that means. And then look up some of those interventions, assessments. What are you going to see? And then what assessments are you gonna do for them and your interventions? So the whole thing is what do nurses do but intervene, okay, for things that aren't working correctly to get them to work their optimal function at the time. So PUD, cholecystitis, okay, all the way around, so that next week we can go through this. I will give you the common interventions and we will go over the specifics. The reason why I do this is because when you are dealing with more than 2 to 8 exemplars, it is easier to know a larger common set of interventions and then a smaller set of specific interventions for each exemplar, okay? It's an easier way to study. It shows you how to apply and it will help you on the test, okay? Does that make sense to y'all? And then this way you can see how they relate and then what makes them different and what interventions work for all of them. Okay? So go ahead and try and fill out the sheet as much as you can, and then we will add and augment. And tomorrow for study skills, if I have you tomorrow or if I have you Thursday, we'll talk to you about your virtual wall space and that kind of thing to use also when you're studying. Okay? Well, it has been a pleasure. Yes, any questions?
Yeah. After cholecystitis, that was pancreatitis and IBD, and what was under IBD?
Crohn's and ulcerative colitis.
Okay.
And what was after hepatitis?
Pancreatitis.
PUD, peptic ulcer disease.
Thank you. We
Okay.
can put it in our own order, correct?
Yeah, it doesn't matter what order you put it in. Okay. Just
So
know
we
I'm
have-
gonna, huh?
Leafy, if we have special pops, we don't have virtual today, correct?
You don't have,
Anybody?
you have virtual special pops, yeah.
She uploaded it on Canvas. We
Okay.
have our class today.
No,
Oh,
today,
okay.
today our class is pre-recorded. We don't have a Zoom meeting.
Okay, thank you guys.
All right. See, this is nice, being able to you know, collaborate this way. All right, so.
I do have a question. I'm sorry.
Oh,
I know
sure,
that
no problem.
you did say that there can be inflammation. Oh my God, hold on, let me go back. Because the way they taught us is you can have inflammation without infection, but you said the other way around, I believe.
Okay, you can have, you do have inflammation without infection.
Oh,
The
but
minute-
can there be infection without inflammation? I think all of us thought you couldn't, but you said you can, right? Is that what
Because
it was?
in those instances with immunocompromised patients, those with autoimmune diseases, that they can't mediate a defense. So their inflammatory response is going to be severely muted.
Okay, got it.
You know, for those on steroids, for those that are malnourished, you know, they don't have.
Okay.
Does that make a little bit more sense?
Yes, because so far I've learned that you cannot have infection without inflammation, but now I know you can. So I was a little confused about that, but thank you.
You're welcome. Yeah, so it's just in those instances. Otherwise, it's a normal response. And like I said, inflammation, you're going to get inflammation normally, okay, for other people, and it's short-lived. And then the healing takes place and everything should get better. But then there are those instances where you have bacteria involved in those kinds of things, and you'll see those signs and symptoms of inflammation get worse and worse and worse. And so that's headed in the direction of infection. But with those immunocompromised people, elderly, malnourished, all those, that inflammatory response is going to be very much muted. Like, you know, it's not going to be in your face like a normal inflammatory response would be.
Gotcha. Thank you so much.
You're welcome. Anybody else? I'm here for you, and I'll open my discussion board later on today, okay? All right.
Thank you, Ms. Leaf.
You're welcome. I will post the recording at the end as well, okay? After about 12:30, 1 o'clock.
Thank
Okay.
you.
You're welcome.